So GERD, what is that? What is the treatment for GERD? Usually there is no specific treatment, but this self-care is very, very important. Anybody coming with minor GERD symptom, you can give some self-advice. They should sleep the head end up. Their head end should be little more than your body level, 20 to 30 degrees elevated, and they should not sleep immediately after meals. They should at least be a gap of 2 to 3 hours till the stomach is emptied into the duodenum. So these are the self, and they should eat more of vegetables. More vegetable diet will cause less of GERD symptoms. If you take spicy food and fatty meal, the GERD symptoms may be more. So antacids, of course, antacids are very good treatment. Antacids, PPIs, proton pump inhibitors. Antacids and PPIs are the cornerstone of the treatment. And of course, in GERD, there's a big role of prokinetic drugs. Prokinetic drugs are the drugs which increase your gastroduodenal motility, thereby they're reducing the GERD symptoms. The gastric transit time, gastric emptying time is shortened. Therefore, the contents of the stomach are pushed down little faster than the normal times. So these are called prokinetic drugs. We have a lot of cisapride, mozapride, and metoclopramide is a very good prokinetic, and even your erythromycin, which is an antibiotic. Erythromycin is also very good potent prokinetic drug. In emergencies, where patient comes with severe spasm, severe GERD symptom, we may give a couple of injections, IV form of erythromycin also. That is also, we give tablets, of course, but sometimes rarely we also can give injections of erythromycin, which is not only, it's an antibiotic actually, but it also acts like a very good prokinetic. So how do you diagnose all these esophageal related problems? One is the symptoms, signs, and at the same time, as I told you, chest pain. You have to rule out all other emergencies like pneumothorax, acute MI, pulmonary thromboembolism. All these pictures are because the site of lesion is in the chest. So we should rule out all these dangerous, serious diseases first. You have to take proper investigations like ECG, 2D echo, X-ray chest, because they are all, they mimic all these GERD-like symptoms. Many times our patients in the middle of the night, they get up and they think that it is gas, and they take some antacid and they sleep. They don't go to doctors, and the next morning they're dead and gone. So we have heard this kind of stories also. So one should be very careful when you are dealing with this kind of chest-related complaints. GERD is most common, but then you have to rule out other diseases first. Endoscopy. After the invention of endoscopy, we are able to diagnose more and more of these gastroesophageal diseases. Endoscopy, you can diagnose achalasia, you can diagnose GERD, you can diagnose strictures, you can diagnose varicose, you can diagnose Mallory-Weiss, all these esophageal related motility disorders also. You can measure the tension, intra-esophageal tension with the motility tension also. You can measure by manometer, esophageal manometers. So endoscopy is very simple, easily done, very quickly done, not very expensive. So endoscopy will reveal many of these esophageal related diseases, and once you diagnose, you have to treat. So the surgical treatment of the esophageal diseases, if there is a big hiatus hernia causing hiatus hernia, usually they're simple. There's no need of any big treatment. But if they're causing symptoms and major discomfort to the patient, you may have to surgically correct the hiatus hernia. The stomach part is going into the chest, mediastinum, through an abnormal opening in the muscle diaphragm. So that is the surgical treatment. And sometimes when there was an achalasia or when the constriction, you can put a stent in the esophagus, or you can do a balloon dilatation. That's the most useful and helpful modality, balloon dilatation of the constricted part of the lower end of the esophagus. These are the different methods of treatment of esophageal related diseases. I think we have finished the esophagus today. If there are any questions, you can comment on Arba's lecture. How did you like him? I am a fan of his, and always he says my ectoderm, my endoderm, my anal plate, and my uterus, and all those things. Arba is a good student and is going to be a good teacher also. Any questions? You can type in the box. If there are no questions, I think we can stop. Am I audible?
Yes, sir. Audible.
Audible. Any question?
Sir, do we still use barium swallow routinely?
Yeah, that's I forgot to mention barium swallow. We used to use a lot previously. Couple of decades back, barium swallow will definitely tell you how your esophageal motility is occurring, and if there's any constriction or any obstruction to the esophagus. Yes, barium. But we are not doing. It's a little cumbersome, and the pickup rate is little less, and you have to ask the patient to swallow the barium paste, which is not really palatable. It tastes like chat, and there's so much of toothpaste like white paste they have to swallow, and while swallowing, we have to take a picture on X-ray, which is not really. I mean, not it doesn't yield the expected results in every case. So endoscopy is the best one. We are not using this anymore. Barium swallow.
What happens if recanalization doesn't take place during embryonic development?
Yeah, if recanalization doesn't take place, you atresia, constriction. So you have to immediately send this patient to a pediatric surgeon, and they will do some surgical reconstruction treatment, and then it depends on how bad is the non-recanalization. If it is too bad, and they will do some pull-through surgery, they will make the stomach into a small esophageal-like tube, and they will do a pull-through surgery. The stomach is made like a small tube, and the tube is connected to the upper end, so that the connection is re-established. But then they're all very complicated surgeries, and in a pediatric infants, the capacity to withstand this major surgery, it's a 2 or 3 stage surgery, and it's very complicated, and there's a high mortality rate.
How to manage if the endoscope bursts during the procedure?
How to
manage if endoscope maybe burst the esophagus during the procedure?
Yeah, that is also I forgot to mention the traumatic esophageal injuries. Usually, the esophagus is good, strong muscle, and the endoscopy that we use is very smooth and doesn't injure. But rarely, in an inexperienced hands, rarely we have seen causing injuries. That's a catastrophe. You will have a rupture of the esophagus, and you'll have mediastinitis and all those. Then they have to immediately send the patient for surgical closure. Though it's a rare thing, yeah, it does occur. Yeah, it is mentioned in the books also. I've not seen any post endoscopy rupture of esophagus. I've not come across any. It is a known thing. But usually experienced doctors, they can do it very easily within minutes actually. I'm sure Dr. Kishore, if he's around, he will agree with me that he must have done thousands of endoscopies. Dr. Kishore, are you there? Can you type if you are there? Yes.
Someone is telling we lost a family person from our family due to this.
Oh yeah, that's what I said. This is a very dangerous complication, the iatrogenic, but extremely rare. I'm sorry about that. I don't know whoever it is. I'm sorry, but this is very less known complications of endoscopy. But if you really identify it immediately and send the patient for cardiothoracic surgery and open surgical repair, probably you may bring him out, but it's a dangerous complication.
Do esophageal webs of the Plummer-Wilson syndrome regress after treatment?
Yes, maybe, sometimes. Okay. If there are no questions, we'll close here and meet you tomorrow night. And good night. Take care.